Welcome to the Addiction Treatment Starts Your Prescriber Forum series. This is the second Substance Use Disorder Counselor Navigator session from a series of 6. And joining us today is Dominique Mcdowell. So he is the Director of Substance Abuse and Homeless Services at Marin City Health and Wellness Center. Mr. McDowell joined the leadership team to create an innovative medication-assisted treatment program to serve those struggling with opioid or alcohol addictions. His program has received statewide and national acclaim and allowed Marin City Health and Wellness Center to bring important substance use and homelessness services to Southern Marin residents. Also joining us on the call today is Danny Contreras. He is the Health Services Manager at the County of Santa Cruz Health Services Agency. He is the Health Services Manager, Danny was the recipient of the 2017 County of Santa Cruz Gold Award for being the key contributor to the development of protocols, procedures, forms, workflows, and implementing the medication-assisted treatment program at all county clinics, which has had a county and statewide impact. So with that, I now want to turn it over to Dominique and Danny to kick us off. Thank you.
Cool. Thank you, everybody. Welcome.
Welcome, everyone.
So week 2, here we go. We wanted to start off with this question. Tell us, what does your intake look like and how long does it take? Like, is there a certain amount of pages? Is it papers only in your EMR? Does it take 30 minutes, an hour, a couple hours, or what does that look like? And what does the intake do for you?
You can stick it in the chat if you don't want to come onto your mic.
Can I add to this?
Yeah.
Yes.
Mine usually takes a good solid 2 hours. We've got about 70 to 80 pages worth of paperwork, and we do a survey that's in addition with that, with like 25 extra pages. So a solid 2 hours, and me walking the client to the clinic to make sure they get their blood work and UA done. So mine is a solid 2 hours.
Okay.
So if anybody has any way of cutting that shorter, let me know.
What is the survey you do at the end? That you said
it's the GIPRA, it's the government. Yeah, the GIPRA. That's like 25 pages itself.
Yeah.
Right. So, okay. And then we already have our like 60 pages something, of paperwork.
Just for your clinic.
Yes.
Okay.
Who's that speaking right now?
That's Tripty.
Oh, Tripty. Okay.
Yeah.
Tripty. Are you in the FQHC, right?
Family Health Center.
You're in the Family Health Center?
Yeah,
oh,
yeah.
San Diego with Dr. Sepulveda.
Yes.
Okay.
Right,
okay.
Right next to him.
Okay. That's my guy. All right. 2 hours.
Yeah.
Okay.
Cool.
Anyone else? John, Dwayne, Elvia?
Well, that's 2 hours with the patient. And then we have to do all the documentation, upload all the documents into EHR, which is another whole process because they all have to have patient labels on them.
Right.
And you're talking about over 100 documents that you're uploading. It takes a while.
Okay.
An intake takes over 3.5 hours altogether.
And you're at the same place, right?
I am at the same Family Health Centers. Yeah. We implemented MAT here about 6 years ago with Dr. Sepulveda.
Right. And when you're saying upload, like you guys are scanning in all into the chart?
Correct. We start out with paper documents and we have to scan it all into EHR.
Wow. Okay.
Okay.
Yeah, I was gonna piggyback on both what Tripty and Dwayne said. Well, specifically Dwayne, I'm also at Family Health Centers, pretty new here, but it takes, with everything that they just listed, it takes me about 3 to 4 once everything's done, and I can step back and everything's in the computer. And then if you count the case conference thing that we do once a week, where we present the new intake to the entire team. Once that's all done, it's 4 hours, I'd say.
Okay.
Wow. And then how long does it usually get to see a doctor? Or to get the medication?
Within a couple of days.
Yeah, 2 or 3 days.
So there's no Med First model there?
Not at Family Health Centers. They can get bridged from the ED.
Okay.
So, and we do suggest that they do that and we have a relationship with 3 key hospitals that are really good about fulfilling that need for the patient, or they're waiting to get in to see the doctor.
Okay.
But they have to complete an intake before we see the doctor.
Yeah, I was gonna say that's pretty convenient too with Scripps, because Dwayne's at a different location than Tripty and I.
Okay,
We're right across the street, literally from Scripps Memorial or Scripps Mercy Hospital. So they go straight over there if they need that Suboxone or the medication that day, and go over there and you know, I'm actually going to be to kind of toot my own horn. I'm excited about it. I'm going to be able to work with the transition to care team, finally starting with Scripps and UCSD to kind of triage patients who are in the emergency department that come in with substance abuse problems and get them in here that way. So hopefully we'll have more intakes. Hopefully I can help find a way to make the intakes quicker as well. So I'm excited about that.
Yeah, that's cool. That is cool.
Thank you, Lizette from Southland, having all your problems, six pages. Did she say, wait a minute, let me read that.
Pages.
6 pages. I was thinking 6 pages, 6 hours. My bad. Okay, Miss Lizette. No one else wants to chime in?
1 hour.
For our process in the NTP program, we do the ASAM usually a couple of days before the actual intake, which takes anywhere from 90 minutes to 2 hours.
Right.
Day of intake, they come in about an hour before the doctor arrives so the nurses can observe them. But that day of intake probably takes another hour and a half.
Okay.
From the time they get here till they see the doctor and get their medication.
Yeah. You're in the NTP. What NTP are you in?
Valley Health Associates in Salinas.
Okay.
And that's you guys doing Suboxone there too, or only methadone?
We do buprenorphine, the pill, yeah, and that's the box, not the strips.
The Subutex?
Buprenorphine.
Wtex.
Yeah, okay. So you NTP, you're under totally different regulations too. ASAM criteria and all that. Yeah. All right. So
anybody else that Elvia, Pat, you guys see it on his iPhone, or anybody else, their intake process?
Hi, this is Elvia, and actually, now that you've asked, I just realized, so we're actually not at any of the clinics. We are actually in the ER, and we're on the very, very start of, well, our program's been going on for 1.5 years now, and we do a basic intake. So we don't really do the long intake.
Okay.
Yeah.
How long does that take you guys?
It's a simple one. We're with the patient anywhere between 30 to 45 minutes, because it's the initial contact that we're making. If we have additional time, then we sit with our patients, and if we don't, you know, it just all depends. It's cues from our patient, and then based on the amount of time that we have.
And is there and then the intake doesn't have any assessments or anything like?
It has just the forms that someone from intake would use. It has the audit forms, just the tools that they answer.
Okay.
And that's pretty much it. Yeah.
Okay. Cool. Juan, you want to go to the next slide? Okay, I guess before we go to the next slide, let's go back. I mean, it's all gonna kind of flow together right there. But you know, I think every clinic's going to be different, or every agency is going to be different in how they do their intake and whatnot. You know, like ours at Santa Cruz is different than how Dom's does his. You know, there's some similarities, and so I would say pull whatever you can from us right now, what we're going to share. You know, or don't if it doesn't apply, and use it. Change it. We gave Juan Carlos the forms too. You can take it and make it your own, or take things out of it that you think would be helpful to your thing. So, I mean, besides doing a bunch of paperwork, what else is the intake good for? And then I guess, do you guys have an intake coordinator, or does every case manager or SUD counselor do separate intakes as they come in?
So for our agency, the day of intake, the intake process itself is handled by the nurses and the doctor.
Okay.
So at Family Health Centers, we have an intake coordinator that she takes the screenings that come in, the people that get referred in to the Family Health Centers, and she sets them up with their initial intake appointment with the SUD counselor. If they're coming from ED, it looks a little different. They may not go through that person. They might show up at one of our clinic-based sites where we have the medication available and say that they're there to get a MAT appointment, and then we screen them and bring them in that way. So.
And that's a little faster process, right?
Yeah. Sometimes, yeah, we usually can see a patient within a couple of days of them walking in to get the intake done, because we have several locations and availability with the counselors to do that. So.
Okay. And then, and as far as when you're doing the intake, like what, like besides doing all the paperwork, like I said, what is your main?
What is it good for? Building rapport, letting them know what the expectations of the program is. Getting to know what their experience has been before they got to us, if they've ever been on Suboxone or not. And kind of calming some of their fears with people that don't know. A lot of people still compare it to methadone.
It helps us look at their level of care to see, are they going to fit in the program as well?
Okay.
Is anybody in this in our group part of doing hub and spoke?
Yeah, we are.
Okay, just want to know. So yeah, it's another access. All right.
What about, I'm gonna throw Margarita out there. What about you, Margarita? I see you just jump on.
What's she at?
So the intake, we do the ASAM assessment, and it's usually myself conducting it. And then the agreement is done with the nurse. And then, yeah, determining level of care, referring out to the appropriate level of care. And just, I think like what I've noticed is that it really helps with building rapport and just letting know the patient that, you know, we're here for them and we're walking hand in hand, and it's about what you want in treatment.
Awesome. And how long does that usually take for them to even get the medications, if the medication is appropriate for them?
To get the medication?
Yeah.
Usually we get them within the same day with the provider or the mat nurse. The intake, like the whole assessment, I think for us, it takes about an hour.
1 hour. Okay. Cool. Yeah, I mean, all you guys basically said all the stuff, but I mean, I think the main thing besides the paperwork is if you can try to condense some of that paperwork down as much as you can. If you can, you know, it just depends on your clinic and all that. But it's building that connection with the patient, you know, that this is, like I said, it's in the last one, is that it's not just a transaction, you know, this is a connection. And I know it's a little different when people are the intake coordinator, because they kind of get all that information, and then they pass them or assign them to a case manager or drug and alcohol counselor. Like at the county clinics, our Santa Cruz County clinics, we don't have an intake coordinator. We had thought about doing that in the past, but we just didn't do it. We kind of, like, all the case managers are on deck. So whenever somebody comes in, we try to get them in. And one of the things, Juan, you can change to the next slide, please. One of the things that helped me, right? We didn't do a lot of the different assessments like the ASAM, because we didn't feel it for us. We didn't feel that it was helpful for us. We basically went to the doctors and said, what do you need from us to do? What are the things, the bases that we need to covered? And then so we built an intake off of that, and made our own assessments basically to try to see where this patient needs help. You know, what are their treatment goals, and to build basically a treatment plan off of that. You know, because it's got to be off what they want. You know, and while you're in that intake, you're building that connection and finding out those goals. But another thing would be too is sometimes we could, I don't know how this is with everybody else, but like for us, sometimes the intake could be a barrier right now at the moment. Maybe maybe we get the bare minimum of what we need to get done because the patient is not doing well. And then we get them a bridge, and then they come back the next day when they're feeling better, or in a couple of days, and then we knock out the intake together. Sometimes it doesn't happen perfectly, but it ends up happening down the road, you know, as we work with them. At least that's how ours is set up. Dom, I don't know about yours. And usually we can get people in like that same day within a matter of hours.
Well, I could speak to this, like Family Health Center, and in the 3 and 4 hours, I was stabbed in the heart a little bit, because We don't use the ASAM criteria. We don't use, I might use the audit, the cows, you know, and use the ACE criteria in our assessments. Because when we formed our program, we totally knew it was medical care. This was not a substance use program. This was medically assisted treatment. We're far away from substance use parameters. So we just use medical treatment, and we created an intake. We took parts from the ASAM, parts from everything, and created our own intake like Danny and them, like we did at Danny and them did. And it takes probably, we can whip through the assessment at Marin City in probably 35 to 40 minutes. And then it takes another 20 minutes to put it into the system. And our patients are off and running. Now, we go back after 90 days and reassess them again. We're constantly reassessing you as you're going through the program. We're constantly reassessing you, seeing what your needs are, because your needs are totally different from the beginning. And even if we do an ASAM score, it's going to change as we go through. So I thought about things we can stay away from, you know, to make it just easier for them. And we do med first model. If a patient come in and they can do a physical with the doctor, 15 minutes, we're doing telehealth now. They do 15 minutes with the doctor. We'll give them a 7-day script. Within that 7 days, they've come in and done the assessment with us. You know, we prescribe first. We get a patient out of pain first, you know, because that's totally uncomfortable to be standing in pain for days waiting to get to see a doctor. So we kind of like wipe that out too. So, and we've done a lot of training with Dr. David Smith and a lot of doctors that's really like into things and really create med first models. Because I believe med first models, this is just my opinion. I believe in any healthcare system, it should be a med first model, because if a patient comes in with diabetes, the doctor's going to give them medication that day, right? I feel like this is the way we should constantly treat it as healthcare, because we're not a substance use program. We're a healthcare center. So that's just my opinion, but every organization is different.
Yeah. Thank you, Dom.
Yeah.
And we kind of went over some of this, but what does the workflow look like to get someone in? Some of you guys have said, you know, they see the nurse first, they see the doctor first. Is anything else different? And people already basically said it took for the medication.
Danny.
So, yeah.
This is Cornelius Thompson, and I'm a community health worker here at Lomita Family Medicine Clinic. And our intake is when the patient sees me first.
Mm-hmm.
That way I can get all the paperwork situated for the provider. I go over all of the insecurities that they may have, and I get that situated. And so it usually takes me probably about 45 minutes or so, depending on the patient, depending on the severity of their health, the issues that they have, because I have them bring in all their medication. That way I can see it. I can chart it down for the doctor. So when they do see the doctor, if they have a need for Suboxone or some type of MAT medication, then usually they'll be seen the same day that they see me, depending on how much medication they still have remaining. Other than that, if there's no immediate need to see the provider, they'll usually see the provider in the next few days. And so it's a smooth transition here, because again, it gives me the opportunity to be the icebreaker for the provider, because from the beginning, I want them to know that I'm here for them. And so whatever their needs are, then I'm the advocate for them. That's who I work for.
That's awesome. Thank you, Cornelius. Okay. Juan Carlos, do you want to switch the slide, please? So this is what I did at Santa Cruz County. Basically, I made like a cheat sheet. All our case managers, we have about 8 case managers, drug and alcohol counselors, all certified drug and alcohol counselors, and we use Epic, Ocean Epic, EMR. We basically made phrases for every note, templates, so they can get stuff done faster. And the same thing with the intake. So you see on there, the slide or the picture on the left, it has intake right there. They basically just hit this quick button, populated in their chart, and then all the stuff pops in, pulls in whatever they entered in, and then they just go through the intake real quick. Usually you can get it done within 45 minutes. You know, it really depends. You know, some people are talkers and you don't want to shut them down either, because they're letting you know what's going on with them and the help that they need, you know. And like I said, it's a great time to build that rapport, you know, and find out what they really need. And sometimes it takes a little longer. Some people have other things tied there, like I don't know where my Medi-Cal's at. Then we kind of figure out where their Medi-Cal's at. We walk them through the process, which only probably 5 minutes to transition their Medi-Cal here. Is it out of county, out of state? You know, there's a lot of little things that we're figuring all out before they even get to see the doctor. But basically, I've tried to make this easy for them, and then I made a little cheat sheet for every visit you see on the right. It's just some things that they run through. Usually they don't need the list because they've been doing it, but sometimes people forget things, you know, just making sure they have certain things covered when they're meeting with them. Because of the GIPRAs, I have add extra time because I have all my counselors on blocks on their templates and schedules, so people can block in. And so I give them 2 hours. You know, if they need it, they need it. If they don't need it, then they see other patients or figure out whatever else they need to do, you know. But I give them 2 hours just because of the GIPRA requirements. They've added a lot of new stuff. And then I don't know, everybody that's been doing GIPRA, they just changed some new stuff. So we're working through a new workflow with that. And hopefully we have that figured out before January 1st. But it just adds a little bit more time to the thing. So I've created that. And then Juan, could you switch to the next slide, please? This is our paper intake. This is basically, we have this already built into our EMR. And we basically just built this because stuff happens. Power goes out, the EMR is down. We're doing outreach on the streets. And so basically it's about 2 pages. There's little sections in there. We're just basic information. You might not even fill it out if you already know all that information, if we already know the patient. But basically, if we have our patient out in the field, we kind of fill this out. And it's kind of double work because we don't scan it in. We just enter this in to the EMR. It's also double work kind of too when you're scanning it in too, because you got to scan that in. We've been trying to work on a system where we can do this out in the field, but the Wi-Fi kind of messed up sometimes. So if you go to the next page, we just cover you know, basic things: living situation, mental health, what's going on, criminal, drugs, any of that stuff, healthcare stuff that the doctor wants to know. And then the plan on the right side is basically just a checklist for my case managers when they're out in the field. You know, sometimes things are going left and right, and there's a lot of things going on in the patients. There's a lot of stuff out there, and they're just making sure they're covering their bases. And not all that stuff might apply to each patient. But that's basically our intake. It's really only like 2 pages, maybe 2.5. And we can run through that pretty quickly. You want to click to the next one, Juan? So this is our workflow at the county. Anybody just shows up, one of our case managers, whether they call or they just show up at the clinic, we get them scheduled for intake. Right after they do that intake, we knock out the labs in UDS. Obviously, those are not barriers. Sometimes patients can't get their heart stick and they can't do a blood draw, so we'll wait sometimes till the next visit or a couple of visits down the road when they're getting and feeling more healthier. We set them up with group. If they're not appropriate for group, then they start doing one-on-ones with their case manager, and then they see an initial appointment. And then they follow up with the doctor or the nurse after the induction, and then they start following the tiers through a one-on-one appointment with the doctor or our IBH prescriber or through the shared medical appointment. And that's basically our MAT workflow. That can happen in a matter of seconds and to a matter of days. Just depends on the patient, what's going on. You know, some patients might do everything and then they just disappear on us. But most of the time it happens pretty quickly the same day. So next workflow, this is Dom's, what they do at Marin City Clinic. So I'll let Dom comment on that.
Okay, so this is actually, it's a workflow for our case manager. So I know it looks like a lot, but this is just all the things that she does, her and my nurse, and I also do this stuff. You know, I as a director, I'm hands-on. I'm in the midst of doing groups. I'm in the midst of intakes. I go do intakes at Helen Vine, at the detox. So I'm like part of the team. I'm not a director that sits at the top and don't be a part of the team. So so we start up, we do our intake is probably 30 to 45 minutes, as I said. If a person comes in, in withdrawal just walk in our door and say that they need help and that we know that they've recently used, we'll just call the ED Bridge program. I'll call the navigator by phone. We'll take him to the emergency room. We'll drive them up there, let them get started on Suboxone, and then they'll come back to us. And then we'll keep prescribing them. And maybe within 48 to 72 hours, we'll call them back in for intake. Or we can go to them and do intake in an outside space. Like probably sometimes we went to people's homes and sat in their yard. We went to the detox. We went to homeless shelters and different offices. So we kind of go to the patient. And it's our MAT program is basically a part of our clinic, but it's its own entity. We have our own lines. We have our own cell phones that they call us on. We have our own area. The only time our patients get to the clinic is when they need to do a physical with the doctor. Either they go to dental or they see a health educator. Our building is totally across the way. It's the behavioral health building. We're in there with the psychologists and the nurses and stuff like that. So we're kind of separated. So our patients really don't have to walk into the main clinic and go through sometimes what patients go through when they walk into a clinic with other patients. But as far as that, our whole staff, our receptionists, our MAs and everything, they're all really trained on stigma. They all really understand who MAT patients are, how to deal with MAT patients, and how to work with people of that population. We have a very kind and knowing, loving atmosphere going on for our patients that walk in, because they know when they're MAT patients. Because we got in part of CFR 42, we've created our own system inside of ECW. We use eClinicalWorks, so it's our own system where we do our MAT intakes in, and only the psychologist and the doctor can go in and see their information. The MAs can't click in and see their substance use information or anybody else. So because sometimes when people come to try to pull out records, if somebody email you medical records, everything comes out. So we had to make sure we protected our patients from their substance use records coming out when their probation officer or somebody else needed their medical records. Everything is slipped out. So we had to make different sections. But so our case manager does follow-ups. She schedules all our patients. She schedules the physicals, behavioral health intakes. We do UDSs twice a week. She do everything it has to do with scheduling the patient into anything in the clinic. Our case manager and our nurse, we run cures reports every week on our patients. Every Wednesday, there's a cures report on each patient in our program, and that's 160 right now. So we're doing between Monday and Wednesday, there's a cures report ran on everybody. All assessments. You can go to the next slide, one, because this is a lot of stuff. It may look like a lot, but this is not. Next slide, one. So this may look like a lot. This is just all she does. This may happen some days, ECW, eClinicalWorks schedule. We do follow-ups every Wednesday. We call all our patients and schedule for their telehealth appointment. So we may call Mark and say, hey, you got an appointment at 3:15. But if Mark's not available at 3:15, our provider will email us our telephone encounters and say, hey, Mark didn't answer. We'll reach out to Mark and say, hey, such and such, and Mark, he'll call back. So we usually do telehealth on Thursday afternoons. My provider will do 15-minute slots. He'll do probably about 15 to 20 that day. And on Friday, he usually do probably 40 to 50 patients telehealth, because we're not doing in-person groups right now. And it's just, we have a MAT provider those days. So all he does is MAT. We keep all our patients on Excel spreadsheets in case the DEA want to come in and see something. We keep attendance, all the basic stuff we do. And we also work with all the patients that our providers in our clinics find out that probably been buying benzos off the street or doing other things, and they really don't want to be a MAT patient, but they want to work in the substance use department. So we'll probably do other outside work with them. We have an NP we have a regiment benzo taper program that we do inside of our clinic with our MAT patients. So we kind of like do a holistic care. And when we were doing groups, we would have our dental team come in like once a month, and they would do all kind of hygiene care with all our patients. We had a health educator that would come in once a month, and she would teach them how to cook healthy meals. And some Fridays they would all go on walks if they wanted to. They would go on hikes. So we would try to make it different. And some Fridays they would come in and we'd talk about the football game last week. It wasn't basically about substance use all the time. Because sometimes that could be boring. When you come in a group, you want to talk about, nobody want to talk about their problems all the time. because, you know, or whatever it is. So we would figure out something to do, you know, play Monopoly, bingo. We would do different stuff, you know, just to give them a family. So, but all of these things that Josette and Golda does this is just a fine printout of everything they touch for our MAT patients, you know, and I think the worst thing that they do is try to deal with people's insurances. I know that could be a barrier. And what we did was, I remember when we first got our CCI, we first got a CCI grant in 2015 to 16, and we were working with Megan. When we had patients came in uninsured, we called CCI and say, hey, can we use that money to pay for our patients' appointments when they come in? So we did that. So I'm probably giving y'all something to ask for when y'all got uninsured patients. So maybe contact CCI and say, hey, you guys gave us this money. Is it all right if we take care of appointments for our patients when they're uninsured? So we can turn nobody away. But I don't know how everybody else's system works. But, you know, if, like Danny said, if there's anything that you guys can use from these workflows to make your life a little more pleasant, you know, because I know you guys have a system that you walked into. I was able to create a system at my clinic that worked best for the patient, because I know it can be really long and drawn out with a lot of time, but it's what works best for you and the patient, you know. But if anything you can take from here, take it and use it. And what I find out, a big thing that I did find out is we would do the ACE. We would use the Adverse Childhood Experience thing when we first done the assessment, and we would always go back 90 days later and do it again. And 8 out of 10 times it would change. We'd find out so much more about people, so much more traumatic stuff that happened, you know, because, you know, coming through the door, they're not gonna tell us everything. But once they're comfortable with us, 90 days, 120 days, and like, hey, let's do the score again. Most of the time, I would always find out things about our patients that they're more comfortable talking about. And we were able to help them a little bit more in different areas of their life. So thank you.
Yeah. So I think both me and Dom had the probably the privilege or being lucky that we were able to just create a system from what helped. You know, we didn't walk into it and this was already built. Like we got to create as we were on the ground doing the work. And so I think that's helped our clinics out and our patients and our doctors. You know, our doctors and our psychiatrists and whatnot, they all pretty much trust all the drug and alcohol counselors. So I think we have more of a model, like Cornelius was saying, that as a community health worker, he's out there and he's the point person, and he sees everybody and basically gets everything off the doctor's plate and then basically presents it to the doctor for the next steps. You know, I don't know how, if any of your systems can change or whatnot, but I know this, that like you guys could put some stuff together and say, hey, this is what works, this is what doesn't work, and maybe talk to your agencies or whatnot, or maybe that's just how it is and that's just what you got to do. You know, I'm not quite sure because I'm not at your agency, but it definitely has been groundbreaking for all of us to be able to build this as we go and see, like, this is what the doctors need, this is what our patients need, how do we meet in the middle, how do we build something that can work for everybody, you know, and have compromises, and as well as getting this basic things met and the patients getting their needs met too. So but which one is the next one? Juan, is that the CM one? There we go. Okay, so I don't know if anybody else has any other questions, because we're gonna do this contingency management question, and I didn't put no A, B, C, or D this time because everybody just answered it quick.
I had a question about the cures report. You said you're doing them every week for all your patients.
Yes.
What's the benefit of that if they're coming in for bi-monthly refills?
Because we're dealing with a population of people that do different things in different areas. When you that's the benefit of it, and our practitioners want to know. You know, we just run cures reports just to make sure they're not going anywhere else doing anything different. And let me scale back a little bit. There's some patients that they may not do it for that week. That's probably been with us a while. You know what I'm saying? But when I'm saying every week, I'm just generalizing.
Okay, gotcha.
Yeah, some that may not get it, may not be on that list. Patient that's been with us 6 months, probably not on that cures report list.
Yeah, I know we have a provider that checks cures all the time. If If
Right.
somebody's, you know, if it's pretty obvious that they're not picking up their medications or they're skipping out, whatever, they can tell where, you know, where they're getting their stuff from.
Right. I should have been more specific when I said that, whoever I'm speaking to. Like, yeah, some of our patients probably not on that cures list, but most of them, like starting, and especially during this COVID time when we're seeing patients less, you know, I think it's really safe to watch out because you can find out so much, you know.
Yeah. And for us, we do it once a quarter, but all our providers, you know, that's their call. They want to do it more. We got providers that are doing it more depending on what's going on with the patient, you know, as they present themselves. And we have had stuff when they're running it. We found out one time one patient was getting Norco from somewhere. And so we had a good, honest conversation with the patient. It turns out that the patient was making money on the side because he didn't have enough money. And so he was going to some other clinic to get that, to help him pay for his necessities. And so then we figured out, okay, well, look, the Watson is working for you. We need you to stop going over there and getting that. And then we figured out a plan for him to have some more sustainable stuff, which ended up getting him, I think it was a Section 8 voucher through something. And, you know, we found out the things, like he was trying to get his needs met, but he was just doing it the wrong way, you know, and just trying to help him, coach him through that stuff. So, I mean, it's good. It's good to do that, and we keep track of that. Like I said, I don't know how everybody else's EMR is, but we can put it in our EMR, and so everybody sees it. And our case managers, you know, sometimes people forget things, so our case managers just look at that and see if it's been done once a quarter. If it hasn't, they might remind the doc, hey, I don't think you might have forgot to put the cures. You might want to check it, you know. Any other questions on the intakes, workflows, assessments? And like I said, Juan Carlos has those documents. You guys can take them. I think they're all in Word form, so you don't have to convert them from PDF. You could change them, edit them, or do whatever you need to do from there. Take stuff out of it. We do other assessments. Mostly the doctors or the nurses might do that. And then the only time that we do an ASAM, which is we do a brief ASAM, is we have the drug medical organized delivery system here in Santa Cruz County. And so some of the other residential programs and IOP programs that our patients might be involved or want to get involved in, we will do a brief ASAM, which takes like 5 minutes. And then we ended up emailing or faxing that over to that program, and then we get them in. So that's really the only time we do the ASAM thing, but we use that assessment that we have and kind of goes from there to IBH or to our primary care. Anybody got any other questions or thoughts? Intake workflows or assessments?
I'm kind of curious. I was just thinking, you both of you guys have been mentioning your providers, your nurses, and your case managers, and then you guys are directors. What are your actual SUDs most responsible for during the workflow?
Our SUD case managers?
Well, I guess maybe you guys are calling it something different, because we have at Family Health Centers, we have our SUDs or SUDCs, substance use disorder counselors, and then we have case managers. Two separate.
In ours, they're the same. In mine, they're the same.
Okay.
Yeah, so they take care of in our Santa Cruz program, they pretty much are the face of the program, the first person they will see for the most part. And then they take care of all the intake, getting the treatment agreement signed, navigating their insurance, checking it, getting it switched over. They do everything, outreach.
Okay.
They run all the groups.
Okay, yeah, it's I guess here I've worked in places where the counselors were, technically case managers as well. Here at Family Health Centers, it's just kind of separated into different places. So
yeah, it's separated at our hospital as well. We have case managers and then we have substance use navigators.
Yeah, so all our case managers are drug and alcohol counselors, and then part of the 12 core functions of a drug and alcohol counselor is case management.
Sure. Oh, don't get me wrong, we do it.
Yeah.
It doesn't necessarily separate. I'm working on housing for like 2 different clients right now, because case management is just, they have to be referred from mental health. So we naturally just kind of become a case manager, but I just wanted to know where you guys made that distinction.
Yeah. What about you, Dom?
My case manager is a recent graduate with a global health degree, but she's been working with substance. She's been volunteering with different substance use modalities for years. So she's not a licensed substance use counselor. And I felt that I could get away with that because we're working in a healthcare center, not a treatment program. I stay far away from, this is not a substance use program. I stay far away from the policies and the procedures. I totally look at medically assisted treatment as what it is. Medications for opioid use disorder. We're in a health center. This is not a drug treatment program. So I kind of stick to that. So I can use a case manager, anyone who knows how to have empathy and for a patient and how to work with a patient who's coming in with disparities. That's all I felt I needed. And they've helped me build something great. And I think our program is really our foundation of our program is just humanity, just bringing humanity back to a person, not making a person feel like their life, like drugs has been the core problem of their life. It's just part of their life. There's other issues that can make a person great, you know, and substances has just made them been one portion of their life, you know, and if we can come in and make patients feel like it's okay to be who they are, and we're going to see you through and we're going to help you get through it, that's it, you know. I mean, I'm licensed in so many different things, you know, but I got a nurse and me, my case manager, and then I got a housing, whole person care and housing, medical assistant case manager. So I got a team of 4 in my office. So I think we have enough capacity to take care of our business. But I didn't feel I needed another licensed substance use counselor.
No, you said it. I think it's important with hiring in any one of these roles, especially when we're dealing with our patients. It's important to have empathy.
Right.
It's important for us to be able to meet our patients where we're at, because, in a hospital setting,
right,
depending on who's hiring, we've had it where we've hired the wrong person, right? Because they don't have those qualities that are needed. They are not meeting the patient where they're at, and they have their own judgment.
Right.
And we can't have that. I would rather have someone who can prioritize our patients, can engage our patients.
Right.
And then, we can teach them the rest of the stuff later. But if they don't have those qualities, your program will not succeed. So
I love you, miss. I love you for that. Because I've had to fire people that were licensed. I fired people that were licensed.
So we only got a few more minutes. I do want to say before we jump to the question, because I want to make sure everybody gets a chance. I don't mean to cut nobody off, but I want to respect our time too. Like at the County of Santa Cruz, I have specifically made it where they really have to be certified counselors. And the only reason why I did that is because we didn't really have nobody that had any type of experience with SUD or any of that stuff, or and I wanted the providers to be able to trust them and know, like, oh, these guys know what they're talking about. It was really hard in the beginning for the providers to just jump on board and start doing MAT. And so all the counselors have been handpicked through the interview process, but it can, hands down, if they have that empathy, that's who you want, and through all our counselors, we have tried to pick the ones that can work in this field. Like Dom said, not everybody that's a counselor is right for this spot or this position. So this is the last question right here. And we're giving out a t-shirt for whoever gets it right. Mona says she really wants to get off heroin, but she is unsure about the Suboxone that is working for all her friends. Mona says she tried using some 2 milligram Suboxone strips that she got off the street a couple times, and she got sicker than she has ever has before. She said it was like being dope sick, but 10 times worse. She never wants to feel that way again. She's really discouraged and feeling hopeless. What do you do?
Education.
Education on what?
Around Suboxone and the appropriate use of it. A lot of times when they take it on the streets, they take it too soon, forces them into precipitated withdrawal. And just education, and walk her through the process, see where she's at.
Okay, thank you, Dwayne. Margarita,
Perfect. I'm gonna send that to Cass.
you said, praise Mona for her attempts in the past and for reaching out for support. Explore how Mona was taking Suboxone. She could have precipitated withdrawal. Explore Mona's goals. 3B, educate on Suboxone and how it works. Okay, anybody else? I think those are all good answers. Dwayne got it right. I mean, you guys all got it right, but I think that's a good thing, right? He said, let's educate the patient. You know, sometimes patients don't know. I've seen people, case managers or drug and alcohol counselors, just like, oh, okay, well, this don't work for you, then go. You need to go on methadone, or you're gonna need to do this, right? And if that's what works for them, cool. But you didn't even do no questioning. Juan, you want to skip to the next slide? You know, like asking these questions, doing some education. What do you use? When was the last time you used any opiate? How many hours did you wait after the last use of heroin before taking the Suboxone? You know, did you have any instructions? Oh no, just what my homie told me, or my girlfriend or whatnot. They told me just take it right away. You know, have you ever took it under a doctor's care? You know, obviously she just told you she took it off the streets. Probably nobody gave her proper instructions. And like Dwayne said, as well as Margarita and everybody else, was that, you know, probably precipitated withdrawal. She just took it too soon, you know? And so, I mean, that I think in itself, you would say, look, hey, you know, you just took it too soon. That's all right. Like, there's no reason to feel hopeless, you know? Let's get you with the doctor and we'll get one of our nurses to explain the induction process, you know, and probably most likely it'll be a lot smoother this time, you know, and we'll be checking in on you, you know? So, I mean, a lot of people don't ask these questions. They automatically just, all right, well, then this don't work for you, get out of here, you know, or refer them to somewhere else. But I think, like, you always got to do that client education. You always got to ask some questions and find out what's going on, you know? It might be that she took it too early, you know? That's what it's on. That's the light bulb that went off in my head when I've had situations like that. Oh, okay, well, how'd you take it? You know, what's going on? You know, you really want to probe and ask, and then support the patient around that and say, well, look, sounds like you might have been in precipitated withdrawal. This is what happens when you take it too early, you know? And so I think that's really good to be able to ask those questions. Dwayne, if you want to put in the chat, or direct message me the address you want me to send the shirt to and what size you wear. But I like I said,
Danny,
yeah,
this whole scenario, you know, we got to be thankful for like ED Bridge programs now. Because like 6-7 years ago, before we really had a way to send patients into places where they can get medical treatment and really be monitored when they're going through this, you know, because I would have, at the end, I would have told this patient as well, hey, I know this is kind of rough for you, so we're gonna stay with you and walk you through this if you're willing, if this is what you want to do, you know, to give them some real comfort, because, you know, as well, you know, and that's why I'm glad I got such a good relationship with ED Bridge, because this type of situation, I would just call them and say, hey, we're gonna get you to the hospital, where if something goes wrong, you're already there where you can get taken care of. So, you know, I think it's really what we do, how we treat people when they come in the door. It totally makes so much difference, you know, like, yeah.
I was actually going to say, listen to them and probably send them to the ER.
Right.
Just, you know, because that's not being a doctor, and where we are, we can't have a doctor come see them right there. And that, since that's where they get their bridge from anyways, we have that relationship and send them over there to get, you know, detox and then start the Suboxone as soon as possible.
Great minds think alike here.
I was thinking that that's such a good way to validate the patient's experience, right? And let them know that we're, like you mentioned, let them know that we're here for them and we trust what they're telling us, so that they can trust us too in the process.
It's a great group of people. I want y'all to know that.
Yeah, thank you guys. We're gonna wrap it up right now. Juan's got some closing things. I don't know if anybody else has any other burning desires to share with us, or maybe some insight that they got from today, or something that they might take away from today.
I just want to say thank you guys for sharing your processes with us. And you know, unfortunately, we only have a doctor once a week, and we don't have that telehealth option set up yet. And we are also restricted to the SUD and Medi-Cal guidelines of an NTP program. So I really like what you're doing over there, Dominique. Sounds great.
Yeah, thank you, John.
And too, Danny, the stuff that you guys put together in Santa Cruz County, pretty nice. How do you guys get around the Medi-Cal? I assume you guys are also billing Medi-Cal, so you don't have to do like that full on ASAM and all that?
No, we don't.
We're not billing Medi-Cal.
Oh, no? Okay.
Our doctors are for their medical visits, but we're not doing it for
Oh, gotcha. Okay.
for SUD.
Right, that's what I'm saying. We go full medical. Ours is all medical. It's not. They try to give us drug Medi-Cal. Like no.
Yeah, it definitely limits you to what.
I'm not touching that. I did that before. No, not in primary care. Why? And it's medical visits. Just build it under medical. That's
Yep.
what we do. Yep.
Our shared medical appointments work great.
Right. I
Well,
think
Danny-
it gives us way more time with the patients, and the process is a little faster. Because I can imagine doing the billing for drug Medi-Cal, doing all that paperwork.
Yeah, that'd be a lot more paperwork.
Hey, Danny.
Yes.
Yes, this is Cornelius again. The one thing that I took away from today's meeting, I like the fact of doing the ACEs in the beginning and doing it maybe 90 days after that, because there's a level of comfortability
right
with the patient. And so trust is built. You have to earn it, and it's not earned in one visit. So I do believe in that process, because it gives people an opportunity to get to know who they're dealing with, to whereas they feel comfortable with expressing the most intricate secrets and details of their life that has been most traumatic, that has sent them to either prison or to drugs. Just real quick, because I believe that the patient voice is the loudest one in the room. And I say that because that's what I believe in, one. And in two, I just had a close friend, like a brother, who was incarcerated, went to the dentist because he was having trouble in his mouth, and they provided x-rays for him, and they seen something entirely different. So they went with what they seen opposed to what he was telling them. And then he had to go back a second time, and he lost his life. He died.
Wow. Sorry to hear that.
So, and that's one of the things that I stick my thumb on, is hearing the voice of the patient.
Thank you, Cornelia. Margarita?
Yeah, I think that I'm taking away from today is like a really good reminder that we have like the picture intake, right, workflow, but it's not always going to happen like that. And just being okay with that, because we'll have providers be like, well, I need this information. Well, I need it too, but the patient's not up for it right now, and we got to meet the patient where they're at. So just I found myself sometimes going through anxiety with that, just working with providers and having to get what they want to and what I need to be doing as well. So just being okay that, it's not always going to happen the way we picture it, but as long as we can support the patient with the medication, and then we'll get to that.
Thank you, Margarita.
Thank you.
I think Juan need to get on.
Yeah, I'm gonna close this out. Well, first, just thank you for all of you for joining us today in this session, and for those reflections that you're sharing right now. And also thank you, Dominique and Danny, for putting an informative session on the importance of having solid workflows and processes and how patients receive MAT treatment. And one thing that resonated with me is like how important it is, if not more, that these processes need to be led by staff that have the humility and the relatability to develop those interpersonal interactions with patients.